Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Well, good afternoon and welcome to Conversations with CEI. My name is Margie Urban and I am the Principal Investigator for the New York State Clinical Education Initiative Sexual Health Center of Excellence. And I'm here today on this podcast with my colleague Daniela DeMarco, who also works with the CEI Sexual Health Center. We both are infectious disease physicians at the University of Rochester. And we are very, very excited to welcome our dear friend and colleague, Dr. Jason Zucker. Dr. Zucker is Assistant Professor of Medicine at the Columbia University Irving Medical Center and is also the PI and Co-Medical Director of the New York City STD and HIV Prevention Training Center. So welcome, Dr. Zucker.
Thank you so much for having me. It's always great to be here.
Yeah, we've had you on a couple of other conversations with CEI, I think most recently about TM7, which is still in the news. And today, we're really excited about this topic. We're using this as a bit of a kickoff for an upcoming presentation that will take place on July 13th, 2026, which is our Lunch and Learn series. And the topic for that presentation is entitled STI Management, Top Papers of 2025 that will impact your management today or tomorrow. And that presentation will be delivered by Dr. Zucker. You can find information about it at ceitraining.org. And again, that's on July 13th, 2026. And if that date has passed, it will also be on ceitraining.org as a CME approved web-based presentation. So with that, maybe I'll invite you, Daniela, to just start us off and, see where we go with this topic.
Yeah, so thanks, Margie. I think this is an interesting topic. And I think, Dr. Zucker, my first question is really, how did you tackle this very tall ask of figuring out what are the top papers of 2025? It was a long year. There were a lot of papers. What stood out to you and how did you get there?
Yeah. So I think that's always a challenge with these things, and it's always inherently a little bit subjective. This is the third year in a row I've done this. And so I have a method that I use that's at least consistent. And I have, 22 top clinical journals and 20 basic and translational journals that we search. So 42 journals. We search across all sort of STI related words and terms and identify any type of study. So we actually identified 173 papers this year that fit into sort of that criteria from the 42 journals searched. And then I try to pick like a top 15 basic and a top 15 clinical public health that I think will really impact the way people manage. Then I sit down with those lists of 30 and then I decide which ones make it into the presentation for more detailed discussion. Yeah.
That's great. And thinking about those general practitioners out there, STI clinics, family planning and what have you, you're probably looking, as you said, this mix of basic science and clinical research. What was your favorite paper, or what do you think was the most influential or practice changing? And I think we'll probably go through a few here, but just thinking of, can you pick just your number one?
I think it's so hard because there are so many great papers over the past year. And I already had to narrow it down to just, a few that we could discuss in great detail. There are some that I think really answered interesting questions for me. And there were some that I think were just really important to the field. The study that they did looking at 1 versus 3 doses of benzene penicillin for early syphilis is a study that I don't think any of us were really surprised by the results of the primary manuscript that was published in the New England Journal, that 1 dose was as good as 3 doses for early syphilis. And that's what the recommendations have been. But what I actually found more interesting than that was actually the sub-study that was done and published, led by Jody Dion, looking at Jerick-Hirshheimer reaction after BPG treatment. We all know that happens, but to actually have a good quantification about how common that happened, that it happens in about a quarter of people, that it's much more common in people with secondary syphilis, that the median onset's about 5 hours and the median duration about 13 hours, I think is really helpful information to provide to our patients. I think historically we provide a little bit more vague, like you may have a fever, It may start today. It'll probably be gone by tomorrow. But to have really hard data to be able to provide counseling to patients, I think is incredibly valuable. We've had so many experiences of people who get injections of BPG for syphilis, spike a fever, end up in the ED, and get these really extensive workups. Having a paper like this to be able to sort of stop that before it happens and provide anticipatory guidance is critical.
Yeah, it's so funny that you say that, because just yesterday I was preparing for this podcast and going through all of these, and I pulled that paper to add it to my talk. It's so often a question. And as you say, it's always, well, historically, this is how it's gone. But it was really, really helpful. I totally agree with that. One other one that I was really struck by that I feel like, at least in our dedicated STI clinic, is a question that comes up so often, was also a New England Journal paper that was about BV partner therapy. I feel like, this is a question that patients with BV ask all of the time. Our answers in the past have been very inadequate to really sort of address the problem of recurrent BV. So I'm curious what you think about that paper.
Yeah, I mean, I think that was probably the biggest innovation over the past year in terms of new knowledge gained, right? I mean, historically, there's been a debate about whether BV is or is not an STI. And I think that question is a little less relevant than whether or not the partners involved and whether or not people acquire BV. And I think what this paper really did well is it makes it pretty clear that the partner is at least responsible for recurrent BV, and that you can actually reduce cases of recurrent BV by providing treatment to the partners. And so I think that's incredibly important given how many people we see with recurrent BV. This is a huge problem. Patients come in with BV over and over and over again, and we've historically not had a lot to offer them other than recurrent treatment over and over again. The ability to offer them partner treatment and to cut BV recurrence in nearly half is going to hugely improve some of these people's quality of life.
Yeah, I think even in the field, it was unusual that in preparing a couple of presentations about that paper, if you look, there were very quickly large articles in the New York Times about the paper twice, with one within days of publication and one a few months later. Up to date changed with a practice changing alert, which is unusual, also within a very short time. And Lexicom and the other sort of drug formulary references also added an indication very, very quickly with one paper published.
I'm not surprised. For us in the sexual health space, we recognize what a problem recurrent BV is and how little we've had to offer people. So the fact that finally there's an option to do something about this, I think I'm not surprised it got picked up quickly, because it wasn't really replacing a different option. It's a whole new option that can really help.
What was your pick, Daniela?
Well, thinking along the lines of innovation, there was a paper by Arti Krishnan about using AI or artificial intelligence to sort of generate new antibiotics, and specifically the structures, combating, or at least another tool to combat antimicrobial resistance. And so I hadn't seen that done before. There's a lot that's new to the field when it comes to AI, but that was really interesting, and I thought holds a lot of promise for the future. And they did have some success in terms of actually synthesizing some of those antimicrobials as well.
Yeah, I think that's such an important paper, especially in the field of antibiotics, where we know there traditionally not been the margins that there are in other fields. And it's really led to a lot of companies not investing in antimicrobial research. And so we don't have as many drugs as we should or we need, according to WHO. This is a potential mechanism to reduce the cost of developing drugs, which means you don't need to make as much money, which maybe at some point will make them economically viable to pursue, helping us deal with the real problem of antimicrobial resistance that we're seeing growing around the world.
Yeah, I thought so too. Anything that we can do to potentially reduce the cost of our healthcare system is great. Thinking along the lines of new drugs, I'm sure you've got the 2 studies for gepotidacin and zoliflodacin, or Gepo and Zoli, as I'll probably call them. Where do you see, in terms of the evidence that's available now, where do you see use for those 2 drugs going when Zoli eventually becomes available later this year?
Yeah, I feel like that's always the push and pull in ID. We get these new drugs, and in this case, we have 2 new classes of antibiotics, which we don't get all that often. And the question always is how do we use them versus how do we preserve them for when we really need them? They have some major advantages over ceftriaxone in that they're oral agents, right? People don't have to come back. In the case of Zoli, it's a single dose. Gepo's 2 doses, so it's a little bit harder, but Zoli's a single dose. And so that's really appealing as well. I think like everything, it's going to be a question of cost as well. I'm sure they're going to be priced quite high. And so initially they probably will be not available for a lot of our patients who might need them. And then I think the question about sort of what the CDC, New York State, and others will recommend in terms of preserving these medications for when we need them. A lot of the early guidance has really recommended continuing with cephalosporins until at least continuing with cephalosporins for now, and then using these in cases of resistant or patients who are failing treatment. And I think that makes a lot of sense given our history. The other thing we don't know is, oftentimes we see these drugs have a lot of success in clinical trials, but then in the real world, we see resistance develop much more quickly. We've seen that with a lot of the novel beta-lactam, beta-lactamase combinations where there's more real world resistance than we expected. And then the last thing is neither of them was as good for pharyngeal gonorrhea as cephalosporin or ceftriaxone is. And that will always be our challenge because a lot of people are not doing 3-site testing. And if you aren't doing 3-site testing, then these really aren't the right drugs for you. But I do think there are certainly opportunities to have an oral agent for people who got 3-site testing, who have genital urinary disease or rectal disease to receive these medications.
So I think ceftriaxone really would be the drug of choice still, especially with the concerns with pharyngeal infection. But gentamicin plus azithromycin is the alternate when you can't use a cephalosporin per CDC guidelines right now. And lots of places really don't carry gentamicin. So would you think that we would still refer out for gent plus azithro, or maybe this would be a role for these new oral agents?
Yeah, I think that's a great point. If you're not at a major academic medical center, you very frequently don't carry gent on your formulary. And so for many sites, it's really hard, and they often refer out for people with true cephalosporin allergies. So I think having these options available might be really beneficial to clinics that are not able to stock gentamicin to be able to use for people who can't tolerate cephalosporins for whatever reason.
Yeah, that's actually the answer I gave when I was asked this earlier. I wanted to.
We think alike. I like that.
What about the dosing of those? Because they both had sort of peculiar restrictions on dosing,
Yeah, I think it's the zoliflodacin is the one that is taken with or without food, depending on the person's body weight. So I think if you're under 50 kilos, you take it on an empty stomach, I believe, versus if you're 50 or more, that you would take it with a meal or with food in your stomach.
I think these are the implementation challenges, right? There's also that zoliflodacin has different dosing for UTI than it does for gonorrhea, which has led to people making mistakes as well. And so I think that it's really challenging when we get these new drugs, especially if there's weird dosing or different dosing for different indications, to make sure that providers who are not doing sexual health on a daily basis, or any of us who are really not using this drug on a daily basis, are able to order it and use it correctly.
DoxyPep has gotten a lot of press, I think, in the last few years. Were there any standouts in 2025 under the DoxyPep umbrella?
Yeah, I think in 2025, we really saw DoxyPep data start to accumulate. A lot of sites really rolled it out in 2023 and 2024. And so by 2025, we really got to see population level effects. The paper that I included in here was the one by Matt Spinelli that looked at sustained effectiveness over 96 weeks. So 2 years of accumulated data in a clinic in San Francisco. And, they demonstrated chlamydia reductions of 83% versus the pre-DoxyPep period in a real world cohort. Syphilis reductions of almost 80%, again, in a real world cohort. And then obviously, I think we're seeing more and more that gonorrhea has smaller or no reductions. But we're seeing dramatic reductions of chlamydia and syphilis, not just in clinical trials, but with real world use, which really suggests that this is an intervention that's really effective and really working well. I have a slide in there that looks at sort of all the real world papers from 2025 that just consistently show large reductions in chlamydia and syphilis, which I think is going to be game changing for the field of STIs.
Yeah. And also consistently really don't show reductions in gonorrhea, right?
That's right. True.
So I feel like we have to sort of maybe tailor our messaging for our patients, to say that despite those initial trials, we really can't rely on this for gonorrhea protection.
I think that's very true. And I'm sure you guys are seeing it as well. But I feel like in clinical practice now, we're just seeing a lot more. The ratio of gonorrhea to chlamydia is much more in favor of gonorrhea than it ever was before.
Yes. Yeah.
Yep. Are either of you aware of any trials looking at doxy-PEP or PrEP in cis women?
Yeah, so Janelle Stewart has the Foxy Doxy trial, which is open now. It's a combined adolescent trials network and HIV prevention trials network study that's enrolling cisgender women. And then I believe there's going to be another study, and I don't know if it's open yet, in Kenya in the similar population that did the DPEP study, looking at weekly doxy-PEP as opposed to daily doxy-PEP. I should mention the Foxy Doxy trial looks at on-demand doxy-PEP as well as weekly doxy-PEP in addition to control arm.
Got it. Very exciting.
Well, so mostly what we've talked about have been the clinical articles, which really are the ones that impact your current practice. But do you have any that are standing out to you from your basic science translational articles that, might impact practice in the future?
Yeah, I think the one that stands out probably the most, because it's a little bit clinically related as well, is the vaginal microbiome influencing chlamydia risk for reinfection and sequelae. They did a prospective longitudinal cohort with deep microbiome profiling, and they were actually to show that the microbiome profile predicted people's risk of acquiring chlamydia and BV, suggesting that some microbiome profiles are more susceptible to infection and others maybe less susceptible, which also suggests that maybe there's something in the future we could do about it by adjusting the microbiome to reduce people's vulnerability to STIs.
Yeah, I found that one really interesting also. That was published in Cell, and it was sort of interesting. So I've been in practice quite a while, and anyone who's seen a lot of STIs knows there's a clinical association between, say, cervicitis, likely due to chlamydia, and BV. But in my reasoning of why that association must exist, I always sort of blamed the chlamydia for the BV, that maybe that infection with chlamydia led to a change in the microbiome and a susceptibility to BV. And this paper sort of turned that on its head and said, actually, it was this particular, a subset of BV really with, particular microbiome changes that led to this susceptibility to chlamydia. So really, really interesting as our scientific advances have led to the ability to really look at the microbiome in much more detail than years ago. You can really tease out these effects. So pretty amazing, really. I think, we all are sort of practiced in this world of sexual health and STIs in particular. I'm older than the two of you, so I've been around a while, but I feel like in the last 3 to 5 years, the field has really taken off. Like there are, important papers, many important papers that look at real interventions, biomedical interventions, which were few and far between in the past. And I'm sort of curious what you think about that, having done this over 3 years of sort of the wealth of papers.
Yeah, I mean, it definitely feels that way. It feels like there's more investment in the STI field. Now, with that said, some of this is years ago because it takes years to take one of these things and put a clinical trial through. So we need to keep that going. But one of the things that really stood out to me is we had 15 different randomized control trials. And to me, that's fantastic because STIs have traditionally been an area where we relied a lot on observational research, public health observational research, and we've not had the number of randomized clinical trials that we really need to be able to really answer the question to provide the highest level of care to evidence-based care to patients. And so having 15 randomized controlled trials in a single year really sort of suggests that a lot of money and investment was put into clinical trials over the past 3 to 5 years to get those trials up and running and bring them to completion now. And I hope that that investment continues and we talk about more and more RCTs every year, because that's what we really need to be able to know what the best course of treatment is for our patients.
Yeah, I agree. So I think the first time you did this review was for our CEI annual conference.
Yep.
And to this day, that is one of my favorite talks. So I'm really so thrilled that you've continued to do it. I encourage anyone who's listening really to join us on July 13th, 2026 for Dr. Zucker's live presentation of his top articles of 2025, or to join CEItraining.org and search his talk. You'll be able to find the recording of that July 13th presentation. So I don't know, do you have any final words? So if you were a family practitioner, primary care provider, where sexual health is sort of part of your daily activities, but not the dominant part, is there any one thing you would say other than what we've mentioned?
One thing is really hard. I would say come to the talk and learn more, because I think we tried really hard to pick articles that will be really helpful and really make people think about the practice they provide patients every day. And really excited that I get to bring this to you. And thank you so much for inviting me.
Oh, sure.
We'll plan to keep up the annual tradition.
Yeah, looking forward to 2026. I now read the articles wondering, will this one make it? All right. Well, thank you so much, Jason, for joining us. And thank you, Daniela, for joining us as well. And again, we hope you can listen to the full presentation and hear about really the great research being done in the field of STIs. So with that, we'll end and hope to see you at the next Conversations with CEI.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.